So a lot of these topics in this group have very similar things to damaged ocular surface. These are my financial disclosures. We've really learned a lot about the stem cells the last, I would say, 20 years. First, the challenge was identifying where they were. Through a lot of histochemical stains and various markers, we've been able to identify that the limbal stem cells reside in the basal layer at the limbus. And then these can progress to these transient amplifying cells, which are in the peripheral cornea. Those amplify more cells and then eventually create the keratocytes in the central cornea. And so this structure, in combination with the ocular surface tear film, is very important for maintaining a healthy stem cell, which then maintains the process you heard Dr. Gomez mention, that XYZ hypothesis of allowing the epithelium to heal through injury. So if there's any breakdown in these areas, you get a limbal stem cell deficiency. And so there's a number of different things that you find when this develops. Some of the first findings would be some early corneal neovascularization. A little bit later on, you can get a pannus and a haze, and that haze can eventually cover the visual axis. At that point, it's fairly easy to tell there's a limbal stem cell deficiency, but sometimes in the earlier stages, you might just see a chronic epitheliopathy that just doesn't improve with treatment. The very classic finding of this late fluorescein corneal staining is very characteristic of limbal stem cell deficiency. It tends to start in a wave-like pattern, usually at the superior or the inferior cornea, which is where the majority of the stem cells arise. And then obviously recurring epithelial defects and delayed epithelial healing, which you've already heard about in the previous talks, become a late sequela of limbal stem cell deficiency. So really breaking this down, you can break limbal stem cell deficiency into congenital causes and acquired causes. I think in the States, probably the most common congenital cause that we see is aniridia. There's different types of aniridia. Autosomal dominant keratitis, this also would fall into what can be called as keratitis, ichthyosis, and deafness, or KID syndrome, which is also referred to as Senner syndrome in the old literature. Early things like sclerocornea for pediatric populations can be a little bit more rare, MEN, mucocutaneous candidiasis, and then these ectodermal syndromes. As you see here, a patient with a clefting ectodermal and clefts. Obviously, secondary causes are much more common, I would say, than the congenital causes, and there's a vast number of things. There's even some other things you could add to this slide. But I think of the more common ones that we see: autoimmune disease. There can be direct stem cell loss from either thermal, chemical, or radiation damage. Non-autoimmune causes are probably some of the more common ones that we see in our practices. Contact lenses being one that's becoming more and more of an issue with longer-term contact lens wear. Certainly infections can cause, whether it be a bacteria, virus, fungi, or even staph marginal keratitis. And then rosacea, dry eyes, and neoplastic lesions of the limbus. We can't forget about iatrogenic causes. If patients have multiple surgeries, if they've had medications such as pilocarpine or beta blockers, mitomycin, some of these can be particularly harmful to the stem cells. Additionally, for glaucoma patients that are on long-term preservative drops, the preservatives can be toxic to the limbal stem cells over a number of years. This is that classic late fluorescein staining. Some in the literature, this can be described as a wave-like epitheliopathy. This is a more advanced pannus or neovascularization, which is developing into a haze from chronic epitheliopathy. And then sort of a very early finding that you might see is a just diffuse punctate epitheliopathy that just doesn't heal up well. And many times this can be in a neurotrophic patient, as we heard about earlier. This disease has been classified now. I think Ed Holland has done a lot to helping us learn more about this in a clinical setting. And this classification scale was first reported in 1996 in collaboration with Gary Schwartz. And this system looks at the stem cells and essentially classifies it into partial stem cell deficiency and total stem cell deficiency. And then also it's important to see how the conjunctiva is. In many of these stem cell deficiency cases, the conjunctiva can be normal, or there can be minimal or severe inflammation. And so, as you'll hear from Dr. Mehta, this system can be really helpful in deciding surgical treatments, as it can be a guide to help you understand what technique to use if you have to go to a surgical treatment. Obviously, in mild cases of stem cell deficiency, there are a number of things, and you've heard these often mentioned in the talks before, because a lot of those neurotrophic corneas or persistent epithelial defects can be developed as a result of a stem cell deficiency. So many of these treatments you've already heard a little bit about already today. I think the biggest thing to remember is those contact lens wearers that are wearing contacts too long. The easiest thing to help out those cases is just educate them about their contact lens hypoxia and get them out of their contact lenses. And in some situations, this needs to be permanent. And that's hard for some of the contact lens wearers to hear, but that really is probably one of the more common things that we can do to help them out. And in many situations, that will help resolve the stem cell deficiency. Intensive lubrication with preservative-free tears is very important. Again, avoiding those preservatives, which can add toxicity to the stem cells. You heard some about some of these topical anti-inflammatory agents, cyclosporin and corticosteroids. In the States, we have a preservative-free cyclosporin, which can be really nice for some of these mild stem cell deficiencies, which is marketed as Restasis. And then certainly the corticosteroids can be helpful for those cases of early corneal neovascularization, as the steroids can sometimes act a little bit like an anti-VEGF inhibitor and decrease the vascularity of the cornea. We heard some about autologous serum tears, and I think those can be really useful for some of these early stem cell deficient cases. And then certainly topical vitamin A can be useful in some situations, which we typically will use in an ointment form. We have a fairly developed system of autologous serum in the States, and so I think it's become much easier to do this. As a matter of fact, some of the eye banks now are actually preparing the serum tears for us. The patients go to the eye bank where they can take the blood and spin it down and produce the serum tears right there on site. In my setting, which is another popular way to do it, is we'll work in collaboration with a compounding pharmacy. We have a pharmacy in our surgical suite, and so our nurses in the surgery center draw the blood, and our compounding pharmacy will then manufacture those drops, and so patients can get those just like a prescribed drug. So it's really become very common and much easier to get in the States, whereas 10 years ago it was more of a challenge. Dr. Gomez mentioned this, and I think these are some of the growth factors that are very important for autologous serum. The serum albumin and vitamin A are also very important. I also agree with him that we like the 20% concentration. There are also reports in the literature of 50% or 100%, but at least in our hands, the 20% seems to do very well as far as outcomes and patient compliance and longevity. We'll typically allow them to keep the 1 month of using these. It's essentially 2 bottles, 2 weeks per bottle. They'll put the other ones in the freezer. They'll typically get about 3 months supply with 1 blood draw at our facility, and so it really can last quite a long time if they take care of the drops the appropriate way. Serum tears are really a number of publications, and obviously for the limbal stem cell deficiency, the Lopez Garcia article down at the bottom shows some particular benefits for autologous serum in the setting of stem cell deficiency. We heard the PROS, which formerly was known as the Boston scleral lens, but now is referred to as the PROS lens. It can be particularly helpful for some challenging cases of stem cell deficiencies. These are the 10 sites currently available in the U.S. where we can have patients fit for a PROS lens, and these are constantly being expanded as there's more education. These are some of the indications for the PROS lens, and obviously the stem cell deficiency being a more common used one for ocular surface disease. Dr. Gomez also showed a great slide on amniotic membrane. It's very helpful to use. We have 2 forms, a Procara form at the top, which we put in, as you saw him show, and then we have a form that's actually placed on the eye, and then a bandaged contact lens is placed over that. It's called AmbioDry. And there's a number of other dry amniotic membranes being developed in the U.S. So to summarize, a number of conditions can create limbal stem cell deficiency. Aniridia is the most common congenital cause that we see in the States. Contact lens overwear is one of the more common acquired causes that we see in the States. And certainly medical treatments can be helpful in limited or mild limbal stem cell deficiency. If you get more severe cases, you'll hear in the next talk that surgical repair is needed for some of those more severe limbal stem cell deficient cases. Thank you.
Thank you, Professor Lee.